Today, I'm talking again to a good friend of mine, Eboni Cornish. Now, Dr. Cornish is a physician who is just put together an amazing career, but somebody who wound up really doing deep diving into Lyme and tick-borne diseases, and now as in a position at the Amen Clinic, the brain has opened up hers and her understanding of it. And so we're going to talk today about a part of the brain that's often not paid enough attention to, especially in people who are walking and talking and not stumbling around. That's the cerebellum. The cerebellum is a part of the brain that I got intrigued with many years ago when I saw an article suggesting that it had something to do with more than just balance and coordination, because that's what I was taught in school. But and over the years, I keep getting hints that there's a lot more to this. And so today we're going to have a chance to hear from Dr. Cornish, and we're going to explore first a little bit of the history of the cerebellum and what it does, and then we will be talking about its interactions with all the bugs and headbangs and things that have to do with our lives. So welcome, welcome, Ebony. Uh,
Oh, thank you. I'm glad you talked about what we learned in school and how much disrespect we gave the cerebellum because we didn't acknowledge how wonderful it was. We even called it the little brain, right? And for those who don't know, the cerebellum is in the back of the head skull right here. And it is small, but it's mighty. And I consider the cerebellum kind of the powerhouse because what we thought, like the movement and coordination, they started looking in functional MRIs, Eric, and they were saying, oh, someone's sitting still, but the cerebellum is still lit up and it's still active. Or, oh, someone's emotional and we're still watching active cerebellum function. So, as we've evolved, our cerebellar function has also evolved around, because we think cerebrum, but the cerebellum has also evolved as humans have evolved. And it's so amazing because it is by these neurofeedback loops connected to other areas of the brain that are truly important to executive function. So I tend, after looking at research and working here at Amen Clinics, to find that the cerebellum is and should be looked at as the CEO and the powerhouse and our major control center. Because when we look at imaging, especially 3D imaging like SPECT scans, we notice that that's where it's the most active, the brain itself. And we also know that the signals that it sends to the front of the brain, which we initially were taught was the boss, right? Because that's
yeah,
the frontal lobe. You think, that's the CEO, that's attention, planning. Also, you think about the temporal lobe, which was on the sides of the brain, and you start thinking about memory and new languages and emotion. And then you go another step and you start deep and deeper into what we call the limbic system. And then we found out, oh man, the cerebellum also affects those as well. So you get that connection with emotion and anxiety and fight or flight and panic. So because of the signals that it sends throughout the cerebrum, I think that it definitely needs more respect and we need to be educated more about its function and its connections.
yeah. The connections are, what's exciting because I think it just lets people have a grasp of like how interconnected the body is. I mean, I know that you swim in that space, but patients, we're just always taught to think about the body as, you got a heart, you got a lung, you got a cerebellum, and you got a cerebrum, and like the cerebral function is running the show.
Right.
And and then they wonder when you get a little compression at the base of the skull, how come everything kind of falls apart? So
Exactly.
what so talk, I just want to hear more about how the cerebellum dances. Well, it's funny, dances is a funny word because we always thought that's all the cerebellum did was dance.
Dance and walk, right?
Teach us how to dance, but that was it. But how does it really interact with as far as let's start first with just thinking, because we always, like I said, it's the reason I have ADD is because my frontal lobe isn't working or firing like it should. So
Yeah, and that holds true for everyone with, just about with ADD and ADHD. But it's more of what the cerebellum, where it feeds to. And like we were saying earlier, the fact that it feeds to that what we call frontal cortex, and that area of the brain is where we get attention, where we have our planning and our follow through and our motivation and our impulse control. So, a lot of times, what I'll see on brain imaging in patients who have things like ADD and ADHD, they'll have slower cerebellar function, so not as much blood flow. And you'll see deficits in that prefrontal cortex, so not enough blood flow there or activity. So that's why people aren't having the control as well as the focus as they should. So it's a direct connection between cerebellar dysfunction and ADD, ADHD, a planning, and impulse control even. And follow through, So that's one of the things, guys, we said we were going to follow through on this webinar with all our questions in this topic and not have as much fun. But no, but honestly, and then when you think of dopamine, right? And we get addicted like to our phones, to the internet, any type of addiction, that's also going to be that frontal lobe. All right. And if you think that the cerebellum is what's sending the signals there as well, you can also get an understanding of how that cerebellar function impacts dopamine, So it's really amazing that once I start looking at brain scans and brain patterns and even functional MRIs, that I started saying, wait, if the cerebellum is imbalanced, the cerebrum is imbalanced. And now, as we take it the next step more to memory and language, okay, that's when we're thinking about the sides of our head, which is our temporal lobe. We have something called the amygdala that we always think about as memory. That's found there. So, with that temporal lobe, you think of memory, new learning, okay, language. And so there you go. Another feedback loop that shows us the signals from the cerebellum can also be associated with memory and language. And the third thing is how it impacts just, those deep structures. And a lot of times, don't you see this, Eric? Your patients come to the office, they're very sensitive to medications, very sensitive to supplements, got all these histamine problems, and they're on fight or flight. Where I look at that, in brain imaging, I look at those areas, those deep structures, and I see if they're misfiring or active, too active, or not active enough. And sure enough, I see that that can also be associated with cerebellar imbalances. So, I mean, it's pretty cool when we think about how it controls so many areas. And that's why a lot of patients, when you've had traumatic brain injury, you start to find problems with all those different areas of the brain, and cerebellar dysfunction as well. So let's not just think of movement, let's think of overall kind of executive functioning.
because what the probably the biggest issue in healing is that sympathetic overdrive, that place where that fight or flight, where there's, I mean, where life isn't that dangerous anymore. And even in people who are well supported and it's all comfy and good, except their body doesn't know it. you
Exactly.
know
Exactly.
and so because when I can you tie I'm just thinking about because movement of the arms and the extremities is something that I always thought connected with the cerebellum, and now that you're talking I'm realizing, but also on some level, that's a real sympathetic drive too, is
Exactly.
the extremity motion. So can you kind of tie that together a little bit for me and just like how you see that? Because and what other parts of the brain is that cerebellum linking to when it's in that sympathetic mode or when it's
Yes.
feeding that sympathetic mode?
So you're absolutely right. And there are also, other disorders where you have movement and gait problems, MS, pandas, motor tics that you might expect
Mhm.
that you'll see. That's all due to the cerebellar's involvement with certain areas of what we call the limbic system, and that's what the thalamus and also the basal ganglia. So when you have that signaling pathway going to the area of the thalamus, that's going to stimulate that fight or flight response. Okay. That's going to stimulate that vagal nerve dysfunction. Those are going to be patients. I always say, if you think that you're being chased by a bear, you're running, and even though the bear's gone away, you're still scared because you've been running for like 20 miles nonstop, and you don't want to look back anymore, and this bear's no longer there. And that's what we are alluding to as it relates to kind of this sympathetic overstimulation that can occur in the thalamus, which is in the deep, I call it the deep areas of the brain. Well, we know that it's signaled by the cerebellum. And not only that, I find that when I'm looking at a brain scan, a SPECT scan specifically, and I see that we have too much what we call activity. Because as I said earlier, when you look at a picture of the brain, you should see in SPECT imaging the cerebellum as the most active. And it should be white, and it should be great, it should be just looking beautiful. But then, in cases like when we're talking about the sympathetic nervous system, the other areas are also too active, like the thalamus. And you're like, uh-oh, this person's brain might need to be feel safer to heal. We gotta get them out that sympathetic response, because if we don't, then they're going to be that patient who has a terrible time responding to supplements or medications, or they keep having histamine, involved, because we know the mast cells innervate the basal ganglia, which is close to the thalamus. That's all a part of the limbic system. So you're like, I got to figure out how to calm that down. And sometimes by calming the limbic system down, you can lead to kind of a feedback mechanism where you have more cerebellar function. And when you calm that limbic system down, patients are now able to receive that those treatments better, and their bodies feel safer. We always talk about cell danger response as well when your body's not, it's stuck. So calming that down and improving cerebellar function tends to lead to better outcomes from treatment, because if not, they're just going to sit there and you're going to wonder why you're not getting better.
So I got two questions. One, I want to talk about when you said cerebellar treatment, what we can do. But before you do that, can you throw up some pictures? Because I realize that I don't think most of us have a really good understanding of just the even the kind of approximate locations of some of these structures. So if it's not
Great.
too, it's
Let's see.
if we can, because I know,
Yep, I sure can.
okay. 'Cause, Um,
All right. So, what we're looking at here, let's start here. So this is from today. So what we're looking at here is a 3D image of the brain. And that's what SPECT scan also looks at. It looks at your brain as if I'm picking it up outside your head, looking the front, the sides, the left, the right. And then when we turn it over in our image, we can see more cerebellar function. But for those who aren't aware, that is, the cerebellar's location. So that's why I said it was called the mini brain. And then when you take another look and we flip it over and we look deeper, and that's called that active part of the brain scan, you can see that the cerebellum, which is in the back here on this picture, is the most active. That's what you should see. You should see so much activity, and you see the other areas of the brain are kind of quiet. But what happens, and what we said here, which is called limbic system activity, is that all these areas here, so like the thalamus, it should show up, but it's not, but we'll imagine that they're now active. So this area here, which is called the basal ganglia, and this middle area, thalamus, that becomes hyperactive. That becomes red and white. That is what we don't want to see, okay? And that's how you get a vision of the limbic system, those three areas on SPECT scan imaging. And a lot of times, what we'll find, Eric, is that the cerebellum just isn't functioning well at all. I mean, it's just low flow, low energy. And at the same time, you know that patient is going to have problems in all those different areas we discussed earlier. So I think just having an understanding of what the anatomy is will really help you better understand what we're targeting as we say these different symptoms. And then just another, this is another really good image here where we're looking at cerebellar assessments. Now, we would actually say that this image is showing a cerebellum that's not as active as it should be because you want it diffusely red and white because that shows evidence of activity level. And sometimes you'll even see it where you don't have any highlights at that cerebellum or very minimal. So you know those are going to be our patients who have more inflammation typically associated with it. Things like Lyme disease and co-infections can compromise cerebellar activity and function. Chronic mold illness can cause that as well. Autoimmune neurological diseases like PANS, PANDAS, even stiff person syndrome, among others, can compromise that function. And it will look completely different on a brain scan image of a normal person. Now, other imaging people might be aware of that specifically looks at the cerebellum are MRIs like what's called neuroquant, which a lot of people who treat mold illness, chronic inflammatory response syndrome as well, biotoxin illness, they do that image because it's covered by insurance usually. But I find that it doesn't give me all the information that I need because it doesn't tell me necessarily about current activity and inflammation. It just tells me the volume of that area. So we'll say, oh yeah, it's smaller, so that means there it's shrunken, and you're not as you don't have the same size of a cerebellum of someone your age. And so that must likely mean that there's SIRS or some type of other involvement impacting that brain, which is true. But the beautiful thing when I compare it to my SPECT scans is I'm like, okay, I can see before and after of cerebellar activity. And more importantly, I can see how cerebellar function and activity is associated with other areas of brain diseases as well as management. It helps my management, and it also shows me how other areas of the brain function as well. So it's kind of like it's interconnected. You can't just look at it as isolated like we were taught to do. It
Right.
connects with every other lobes and other areas of the cerebrum, which makes it so important that you have visual access to its function, which is what I find it helps, especially in these complex patients who have chronic illnesses.
So when you're looking at that, when people are having a SPECT scan done, so you can actually have them engage in activities that you would expect the cerebellum to light up in doing different things, and see if.
Yes. So we do what you call a baseline scan, which is when I'll put you because a SPECT scan, it's not an MRI, as I said earlier. It's a special type of brain image. It takes about 15 minutes. I put you in the machine and then I let you relax. Okay. And then the next day, you'll do a different scan where you're given certain games and activities to make you concentrate and focus. So as a result, your brain should be more active. And if you have what I think of like a slower, a sluggish, not that active cerebellum, then boom, when you're concentrating and focusing, you want more activity, right? Well, what I find in a lot of patients who have chronic infections and toxins that are causing the brain to be inflammatory, that the cerebellum doesn't change. It's going to have low function no matter what you do or how hard you concentrate. And that can lead to that symptom of cognitive impairment, brain fog, tiredness, fatigue. So that's something beautiful that I like when I look at the brain. I'm like, wow, I'm comparing this person is now concentrating, but that cerebellar function is still bad.
Yeah. So you actually see clearer signals from the cerebellum than you see from the frontal lobes when it comes to those kind of stimulation.
Exactly, you
That's
should.
okay.
But keep in mind, cerebellum sends the signals to the frontal lobe as well.
So
But commonly in TBI, this is another because this is important and it relates to what we talked about with the imaging. When someone's hit their head or had traumatic brain injury that's led to cerebellar dysfunction, you're also going to see that prefrontal cortex and temporal lobes typically dysfunctional as well, have less blood flow, less activity, and that won't change either. That's another image where typically you don't see any changes per se. The only time I see, well, they see a lot of changes with patients from the scans one day to the next with mood disorders, especially with ADHD, the different types of ADHD. And sometimes, depending on that limbic system, if the person's in fight or flight, and then they might take medication that calms them down. And if it works, you'll see a difference. The limbic system becomes more relaxed. So, it's beautiful, like the comparisons you see and how. And I look at that first, even before a patient walks through the door.
Okay. And when you see people with you mentioned earlier some of the twitches and the movement disorders and the what I always forget what euphemism the neurologists use for the for for seizure-like activity that
Hmm.
does not correspond to what they would expect to see.
Pseudo seizures.
Yeah, well, they have many euphemisms for it, But can have you do you have a way of describing them? Can you actually see the changes in people's brains who are having those?
Who are having like the motor tics,
Yeah, motor,
like ataxia. Yeah,
motor tics or
definitely. When I'm looking, especially, let's say, at my PANDAS patients, right? We know cerebellar is going to be low in activity, because that's our movement center. But we also find higher levels of activity in areas where there's more anxiety, and also more OCD or obsessions. So those are areas, that's a different area of the frontal lobe. It's something called the anterior cingulate, which in a lot of my PANS and PANDAS patients, it's very active because that's responsible for obsession. And then you'll get kind of, what we consider a ring of fire, where there's hyperactivity on the SPECT scan diffusely, and sometimes with or without high activity in the cerebellum. And then you say, okay, this is a kid who has really bad OCD. They're probably going to have motor problems, memory problems, mood problems. And those are typically the kids that we know, and even adults that suffer from neuroinflammatory conditions. So, those are things we can directly see, and we can also see improvements when those areas. And as we're going, I'm seeing if I can pull up some images, and if not, I'll pull them up next time. But let's see, because I
yeah.
think I might have something. Yeah.
What's what's interesting. So it sounds like you can really see the difference many times between people with neuroinflammation that's more from tick-borne diseases, mold versus TBI.
Right, definitely. Because the difference is with usually with neuroinflammation, you're gonna have areas where there's like the top of the brain that's very active. And it's something called scalloping, which means it's kind of uneven in the appearance that you have on the image. And so that's what we call like an inflammatory brain. And here I got some good examples now for you guys.
Okay.
All right. Now we're cooking. All right. So, all right. So, this is kind of what healthy scans look. So, remember, SPECT scans are 3D image. So, we're looking here, we're looking under surface view, right surface view, left surface view, and the top of your brain. And there's a cerebellum here. So, this is the surface, okay? Colors don't matter here when you're looking at the surface. All that matters is that everything is full. All right, full symmetric. And then you're looking deeper, and this is the active scan. So remember earlier we were talking about activity, and if you see here, that's what I mean. That's when colors matter. That's the area of the brain that should be the most active, which is the cerebellum. So when we have toxicity, okay, it's not healthy. So it's kind of because this is looking at blood flow, there's a problem even in the back. That's where you have this uneven appearance. So those are the patients when I'm treating and I'm like, okay, they have cerebellar signs. They have abnormalities. Is this toxic or not? So I'm looking for more of this scalled appearance. And then I'm also when I said earlier, you have the person who's in fight or flight. So this is a Lyme patient who was in fight or flight, wasn't responding to therapy. Now, as you see here, her brain had activity all over. I
Right.
told you earlier she looked like this. So when you see this, I'm thinking, okay, not only because I know cerebellum innervate sends signals to other areas of the brain, I'm like, okay, this is going to be a person who's going to come in. It's going to be either not responding to therapy, having a histamine response. Sometimes when you see these four areas, so this is the basal ganglia I was talking about earlier, and the thalamus, which I said was the limbic system, and then the top, which is the anterior cingulate, which is OCD. So I'm linking to her. I'm like, oh, okay. When you see all four of these, there's gonna be some trauma because that's a pattern for PTSD. There's gonna be some anxiety. There's gonna be some compulsions. All right. Even though the cerebellum is active, all these other areas are active as well. So that's inflammation too. All right. So I'm already prepared mentally. All right, for that. And then those are the areas we talked about before, the basal ganglia here. Cerebellum is still the boss. So I want you to imagine that cerebellum is still sending signals, okay, to other areas of the brain. And I'm going to show you one more, guys. Don't say, why didn't she go over all her slides? But you're getting some fun stuff here. Let me just bring up one where the cerebellum is it's I call it night night. It's just it's not there. It's just shut down. I mean, it's like the whole brain is quiet. So
Yeah.
let's see. Well, we can continue with questioning as I
Yeah. Yeah.
look that up.
Just what
So yeah.
what I'm finding is that so well, what I think I'm hearing is that you have just a much more complete picture because one of the when I'm like when people look at like the QEEG, the surface electrodes, they're really not paying much attention to the cerebellum.
Yeah.
And I think that's why they read everything as TBI because they can't differentiate.
And that's true. And that's why, like I said earlier, in TBI, most cases you do have cerebellar dysfunction. I mean, that holds true, but you can also have the temporal lobes, those areas I told you responsible for
Yeah.
memory. You can have mood instability, so often when we have those other areas involved, you're going to start seeing mood changes, like more depression, more anxiety. as I said, brain fog. So that's what you don't get from a functional MRI. You just get, just an image. But that's why I love looking deeper, because then I can tie in, even though I'm not psychiatry, I'm family practice, but I can look at with our algorithm as looking at 250,000 scans, a mood pattern that can also coexist with a trauma pattern. And and you get the patient gets the fair treatment that they need, because we always think about football players and boxers and those who we know have had tons of concussions, and wonder, well, why did their moods changed? Well, their mood changed because most likely cerebellar function changed, and that led to issues with other psychiatric conditions because of its interconnection with other lobes and areas in the brain.
And so going back to our mold and Lyme population, when you, I guess it's that question of, because so many times, once it's been there for a while and the brain is inflamed and then everything starts irritating, we do see lots of mood activation, or either um, irritability or depression or both. Is there particular patterns you see with that?
Yes. So a lot of my patients with tick-borne diseases, because we know that there is a neuropsychiatric manifestation of these disorders. Dr. Bob
Right.
Bransfield has done numerous papers showing this. And what I find in patients who have tick-borne diseases, it's all over the map. I mean, when I tell you all over the map, besides the inflammation piece that I showed you that seems to be consistent, people can go from low activity diffusely in the brain. So hypoperfusion. And if we just take a step back and recall what I said earlier, if you're not having as much perfusion to areas that are responsible for your mood, your attention, your focus, okay, your forethought, your follow through, then you're going to definitely have some abnormal, clinical signs and symptoms associated with your mood. So when I started working at Emmett Clinic, it was because they would get spec scans. This was over 15 years ago now when I first started collaborating. And they would have images and say, wait, we have this algorithm for psychiatry, but they also have a pattern we can't quite explain with our psychiatric algorithm. So let's do some deep digging and find out what the root cause was. And the first patient I treated, they were a Lyme patient. It was one of the scans I showed you. And they failed like 30 meds, literally 30 different psychiatric meds did not get better, because you can't treat these complex chronic illnesses with psych meds. So body health is brain health. And so with tick-borne diseases and mold and anything you want to think that's neuroinflammatory, SPEC scans not only allow me to know what areas of the brain are imbalanced and where I need to target, but it also can help guide my interventions. Because if I see cerebellums that are low in activity, then my treatment might be different from someone who I see who has an active cerebellum, not much inflammation, and maybe they're just dealing with trauma, or they might just be dealing with a limbic system that's in overdrive, and it helps me change my clinical course. Because how many times have we seen patients, they've been treated for so many years, they don't get better, and then I look at their scan and say, wait, there there's something else we need to do. They might have had trauma to their brain. They may be going through trauma to them, because so many of my patients with Lyme, they have PTSD from being misdiagnosed and all the
And
things, mistreated and thrown out and on all the wrong, in this 20+ year journey and 20 plus doctors. I mean, that's traumatic. And you got to fix that too. So why you can't just treat underlying toxins? In fact, you got to treat the brain as a whole.
right. So we're going to go to questions in about 2 minutes. I just I have one question. My question first. Then we're going to go to questions. Is just, when I think about, evolutionarily, we always think of the limbic system as being there, the reptilian brain. So
Yes.
the cerebellum, where is the cerebellum in that in that evolutionary story?
So, I mean, I think that cerebellum evolved as the human evolved, as we evolved in our functioning. Because I think about when I first learned about cerebellum, we thought of fish, and we look at fossils, and then we see that it has grown not only in function, but also evolved in size as well along the cerebral cortex. And I'm like, oh, that makes more sense. So, I think over the years, we're starting to get a better understanding, even from where we were when we were first learning about its growth and about how it's evolved. And that also let us get a better understanding of all the different areas it affects. So that's kind of the difference. As we've evolved, our cerebellum has also
Yeah,
evolved.
it just seems like it's so close, it's so physically close and intimately involved with that brainstem,
Yes.
the whole, limbic system. It
Hmm.
seems like it's the undercarriage. Seems to be, it seems to be running the show. So,
Yep, it's that silent little player that you don't
yeah,
think about. Like I always think of it like those dogs. I'm sorry if you have a small dog. I like big dogs, all right. But those small dogs who are always yapping and running the household, that's the cerebellum.
it's making the noise. So let me ask some questions here because they're really good one. Um, just one that I think we just should really clarify. Yeah, because can cerebral ataxia slash cerebellum cause falls and balance issues?
Of course,
Yeah.
yes,
And again, that's the cause, right?
right,
That's what they do. And
yes,
having long COVID. Well, long COVID's I'm gonna get that one. Increases inflammation, and as Ebony's telling you, increasing inflammation is going to make anything that's not working well work less well.
exactly.
Um, you know, and but a good question, whiplash and the cerebellum.
Hmm.
So w- I'm going to let you deal with that. How, um, yeah, obviously, anything that's going to make the head move real fast like that. But I mean, again,
Hmm.
people always think about, every time you have a whiplash, everybody's always pointing to like what it's going to do to the, the frontal lobes or
Hmm.
or the side of your brain,
Hmm.
um, or just your neck. But
Hmm.
does the cerebellum take much of a hit there as well?
Yes, definitely it does. I mean, because what happens when you have whiplash, you go frontal lobe and then something whiplash to the back of the brain. So yes, you do see a cerebellar involvement with whiplash, car accidents, of course, concussions. You can have a decrease in activity. When you get out of whiplash, sometimes that patient, you're walking, you're unsteady, you might have ataxia. That's definitely a cerebellar sign, but there is definitely shown in case studies and in patients who have had car accidents, whiplash and the like, to have some cerebellar dysfunction associated with it.
Okay. Yes, I'm sorry. Somebody's hate reading these questions because sometimes I go down rabbit holes. Okay, and just one of the easy one of the questions someone asked is about using cranial sacral therapy to calm down the brain and nervous system,
Hmm.
um, and they're asking what of our experience in allowing that to help, then be able to treat MCAS and mold and post-concussion syndrome, et cetera. You know,
Hmm.
and my 2 cents is, yeah, cranial sacral therapy is a great way but their point is without backfiring and getting huge flares, because that's, people are always worried about that. And
Yes.
again, it depends on the treater because I was trained in cranial back in 92 and I did it for many years. And one of the reasons I don't do it much is because I wasn't good enough to really sense when the body had enough
Hmm.
because
Hmm.
it can feel really good and the
Yeah.
patient's feeling really good,
Yeah.
except right afterwards or the next day, the patient, it was too much. You moved too
Yes.
much. So
Yes.
yes, craniosacral is wonderful, but just be aware of
Yeah,
your
yeah.
body and be aware that the person doing it is someone who has experience treating people who have these complex chronic illnesses. Because if they've just been treating the average person, they're going to overtreat you, and not because they're bad, it's just because of experience. So,
And I agree. And I think that that holds true for a lot of treatments, for our patients. If you go hard, even like with regular massages, you're going to be releasing too much at one time, and it will cause, I call it like the Herxheimer of treatments. When you're going too fast, you're releasing too much, a person can't clear it out, have too much cytokines that are being produced. So, yeah, definitely.
yes, and here's well, a few good questions. Just yeah, see if you have a different answer than I would. If the cerebellum is less active and the brain is more inflamed from tick-borne illnesses and mold, can this be fixed? Of course, but
Of
well, I guess
course.
it's asking, of course, but I mean, are you using more, are you treating the underlying causes more, or I mean, which I'm sure you are, but is there something more direct that you can do to help the cerebellum? I think that's the question, right?
Yeah, so cerebellar, and let me just, because I did make a slide about that as well for you all, just talking about the different types of treatment that I use depending on a patient who has cerebellar dysfunction and other causes. So, of course, what you do primarily is you're gonna address the root cause. So that means treating the underlying infection, that cause of inflammation. You also have cerebellar dysfunction. I have patients who come with years of Lyme disease, long COVID, mold, and they haven't treated sleep apnea, or they haven't treated that, autoimmune process that's going on. So you got to look at the toxic metals. You got to do the detective work to find out what the problem is, because that definitely needs to be addressed. But at the same time, if you find hypoperfusion in the cerebellum, you got to increase blood flow. All right. And I find, a lot of these vector, if we just concentrate with vector-borne diseases, some of our co-infections like babesiosis and Barnella, they can integrate into the red blood cells. And what gives us perfusion? The red blood cells. And where are the majority of our red blood cells? A lot of them go to the brain. So when there's cerebellar dysfunction, no matter what the cause is, you want to increase that perfusion. So I found a lot of benefit when I look at scans before and after that may have had, trauma and hyperbaric oxygen when you're putting someone in a very high oxygenated environment. Also, I use things like systemic enzymes, nanokinase, serrapeptase, lumbrokinase, which are derivatives from earthworms that just get that blood flow going. Okay, get those vessels working, get rid of those bad proteins that might be preventing blood flow, or also fibrin to get it perfusion going. And then some of the areas, the things I use right now, sometimes I have to use heparin, to help them get through, and then, the ginkgo. And then, mitochondria support is also important because you want to give the mitochondria, which is an energy source of our cells and our body, what it needs so that it has enough juice to start the healing process. And then the cognitive motor rehabilitation, that's something I didn't focus on earlier, but it is so key. So, as I said, there are areas, the limbic system, that when it's in overdrive, like the analogy of being chased by a bear, when it's working too hard, okay, the brain doesn't feel calm or feel safe to heal. And what needs to happen is that you might find yourself being required to do non oral treatment modalities. So that might be something like a neurofeedback or a biofeedback, which changes the waves in your brain so that it calms down the limbic system. Or if someone has trauma, and that's another pattern, PTSD, that I can see on brain imaging, I might use electric EMDR, which is another non oral form of treatment just to calm down those areas that are too active and also help that person deal with that trauma. And that treating that those imbalances, Eric, can sometimes on post images, like after going through treatment, you'll see increased involvement and activity of the cerebellum because it was kind of stealing those areas, the activity that you needed for the cerebellar function for the limbic system to be in overdrive. So calming that limbic system, that's why it helps so much with treatment, with cognition, with focus, and also with cerebellar function
Yeah.
because you reset the brain waves. And you can do the same thing. People may have heard of Annie Hopper, primal trust, reorigin, all of those limbic system modalities that you can utilize to calm it down. And it helps with
Yeah.
cerebellar function as well.
And I just want to emphasize is as you're laying these out that it we need a repository somewhere. Someday we'll have it of the literally there's got to be, I mean, I know there's hundreds, it's probably 1,000 different modalities that people have developed, okay, for working with the immune system, the neurologic system, the inflammatory. I mean, there are so many ways in. And, being doctors, like you're saying, we start off with like 5 or 6 meds, and that's what we're using. And maybe we get to 20, but it's or 30, and then we add herbs. But there are so many, as you're describing, the EMDR and there's so many different biofeedback schools. I mean, forget it just about neurobiofeedback. There's got to be 30 at least. I can think of, if I can think of 10 offhand, there's probably at least 30 schools of neurobiofeedback.
Oh,
And
yeah.
people talk about cranial work. The same thing there. There are so many different techniques because brilliant people come up with an idea and they find a few people that it works really well on, then they develop a school.
Yeah,
But the problem is it doesn't work on everyone. And
exactly.
what we're looking for is just some way to be, this is my goal, some way to figure out what fits whom. Because, but until then, all I can tell people is just remember that yes, every time you ask a question, can this help? There's probably something out there that can help you. Now, the frustrating thing is what's for you, and then we're stuck with just you got to talk to us, and hopefully we know something that will help you, or
And that's why,
you'll find it on the internet, or it helped your cousin. Just be aware that just because it helped your cousin, it might not help you. So I'm sorry I went down that rabbit hole, but I
no,
just want
it's an
you to
important one
know that
because,
there's
yeah,
hope out there. Some things will work.
yeah.
I'm just gonna just I want to give there's so many good questions here, and I want to get some of them to you that are more specific rather than like, yes, there's help, and these can be figured out. So just someone's asking about is there an emotional effect of a small cerebellum in like autism spectrum or Asperger's?
Yes, there definitely is. So it's not necessarily that they have smaller, in all cases, cerebellum. They may have low cerebellar activity. And like you were saying earlier about, the reason I started treating, because I treat the disorder, I treat autism and Lyme, all these illnesses, like we say, we have to get a whole plethora of treatments and we learn every single day something new. Well, my problem was, okay, I'm learning this. They still have neurological changes. Well, do I have the ability to see if my what I'm doing works or not? I got all these tests in the world, but if it's the brain, and if I know, like especially for example, in my autism patients, there are things I use like leucovorin and DDAVP, and then I'll try, find out their root cause if something else is making it work worse. And then I can see before an active scans, and it'll tell me, okay, this is kind of what's going on in their brain for better or for worse. So we definitely see cerebellar dysfunction, but we also see either it can be because we don't have one answer, it can be too much activity in the brain like that ring of fire where everything is hyperactive, or low, severely diffuse low function of the brain. So I tend to see even in chronic diseases, I know this wasn't the question, but this is also an important analogy. Um, in chronic infections, I see that happening. I see very high activity early on because that's very inflamed. And then when we're looking at the active scan over time, as it becomes more chronic, I see less activity diffusely. So with autism, there's definitely patterns that are different. And a lot of times you can use images before and after treatment to see if they're kind of getting anywhere neurologically, just
So,
image wise.
so two more. A quick, actually, one question somebody asked. I don't think the SPECT scan is that covered at all by insurance? Well,
Unfortunately, only care credit. No, it's not.
I didn't think so. Just funny.
But we do have insurance, officer that people that I know have gotten it paid for. And then we have resources like we were doing a project with the firefighters in California. And
Yeah.
we also have a Change Your Brain Foundation where, depending on your needs and your resources, we do offer, if you're a patient of our clinic, some people, very select cases, but you can get grants for free scan funding. So we have options to make it available. You have someone there that works and gets it if it's a third party. We have someone in the insurance department that can help, apply for you. They won't fill out the paperwork, but they can give you codes you can use. So I wouldn't say it's always only cash. We do have, I've seen a lot of foundation patients as well. And we just had a big, with the fires in LA, a big surge in grants for those firefighters.
That is wonderful. So I just got lots of questions. So like this is an interesting one. Please discuss what you've seen in long COVID, cerebellar dysfunction, and treatment for that. Because I just want to start with a caveat that um, most I say, yeah. I don't know, a large number of long COVID is really just rekindled old infections, but then and other issues that are, you know, but then there are the long COVID people who are really is because there's persistent in COVID or spike protein. So,
Mhm.
I'm going to reframe that question. So, in your view, have you seen, is there any way that you think you can discriminate between the people with persistent spike activation versus people who have just recurrent, or reactivation of their Lyme or EBV or some other thing that's gone along with the long COVID?
That's a great question. And the problem is, just like symptom wise, they overlap. I tend to, like you alluded to, look at
Yeah.
COVID as being kind of because it's one of the most histamine driven organisms known to man. So it causes a really high histaminic burden. It causes immune system to be compromised. So then other infections flare up that your immune system at one time was able to keep in remission. But the SPECT scan doesn't tell me this is a long COVID versus a Lyme brain. It tells me what questions to ask if there's an underlying, symptom, because I'm a doctor first, so I'm a clinician, look at their clinical history, right? And then if I see a brain and that's consistent with their clinical history, then I know what tests to do, and that's the approach I take. So I'm not going to say scan A is only Lyme, scan B is only long COVID. You're going to see patterns. You might see the frontal lobe being impaired. You might see the temporal lobe being in certain areas impaired, cerebellar involvement. But more importantly, you see an inflammatory presentation, and then okay, the next step is to figure out why that's happening. And that's a lot of times what we'll see. And we actually Dr. Amen has some, we haven't published research, but he has a lot of data on before, pre and post COVID cases. And we know a lot of them had mood changes too, right? It wasn't only, immunologic changes. They had a lot of psychiatric side effects post COVID. And you can see that those areas, those different areas of involvement in the brain, like the frontal lobe, especially being dysfunctional and cerebellum in those cases, and that first thing, the anterior cingulate. So yeah, so you definitely can see patterns, but it's not specific enough to say one versus another. You
Right.
still need a clinical picture.
Yeah, Figured. We'd love to have. We're looking for the the black white answer
I
that we.
wish. I
Yeah.
wish.
So this is a good one. I've been thinking about this myself. So can chronic brainstem well, yeah, you could have a little. Yeah, you do actually. Just the increase the increased congestion that you can have at the base of the brain from CCI, from
Hmm.
cranial cervical instability or
Right.
some or other issues down there, Chiari, can that uh yeah cause like a TBI like effect on this on the cerebellum or the brainstem? I mean,
Yeah, I mean, that's a good question.
yeah,
I mean,
I
technically,
don't
if I think of it just from anatomy, it probably could,
yeah.
right? So, but like I said, like let me just see if I have a picture to show you. Oh, it won't show. But yeah, so I have, if you imagine, you have to pretend to see this, pictures of TBI brains and infectious brains and inflammatory brains that can overlap, and they can look quite similarly, especially if you're talking about activity and blood flow to the cerebellum, but it's still based on that person. So I wouldn't say 100% yes, but I would say it's a high possibility because I never say 100% that you're going to see the similar changes.
Yeah. So there's another good question about safety, just well, almost about money. This is about safety. The concern about the radio, about the contrast agent used in the SPECT scan, effects on the kidneys.
Yeah. It's the contrast you get what SPECT scan imaging is like 1/4 as toxic as the tracer material you'll get from an MRI or a CT scan. It's and that's why I love SPECT scan imaging because it's less toxic. I do a lot of studies in heavy metals and gadolinium, and I have a lot of very sensitive patients who can't tolerate anything. So over the years, we've had to do more research into the material, the tracer material we're using, and the complications. And honestly, there's a high percentage of patients that can tolerate it without problems.
Yeah. Is there anything that people can do to make it easier to tolerate, or is there any concern of any of it staying in the brain or the kid or the brain and the kidneys? I mean, is that an issue at all, or is that
Well,
something?
it's less of an issue, but I think for anything to be entered into your body, things like detox will be helped. That's for anything, things like glutathione or, Myers cocktail or Epsom salt baths or NAC, sorry, those things that we naturally sauna, sweating, water intake, those things that just help get your detox pathways and keep them open should be used for, any type of foreign or image or dyes that enter your body.
Okay. And in someone's, is there a connection between the cerebellum and hypermobility?
So I that's a great question because I have a lot of patients who have Ehlers-Danlos. I had treated a lot because it can be due to mauve mold and vector-borne diseases. So I would say in some of those cases, I have seen cerebellar dysfunction on their scans, but I can't say it's 100%. But if you think of movement, mobility, you would definitely think there was a correlation there. And that's an excellent question.
Yeah, there's so much. And somebody asked a question that I would love to have the answer to someday. Lots of these questions I'd love to have the answer to. Yeah, but is plasmapheresis helpful for cerebellar dysfunction? And I would say we have no idea
No,
yet.
I wish I would, Eric, figure that one out, man.
I mean, I'm
I'm
laughing
leaving
because
that up to you.
yeah, well, I mean, it's something hopefully we will figure out someday. I mean,
Yes.
it's God, the difference between what we think and what we know is so huge in medicine. I wish people have, unfortunately, because the way medicine presents itself as like as we know, and which is it doesn't it's just so wrong. We don't know. We
Mhm.
have ideas. We do not understand how this body works.
Right.
We can't know.
Mm-hmm.
That's another whole long story there. And the last, I mean, let's end with a simple one.
Uh-oh. Simple. None of these.
No. 'Cause what is the difference between the brainstem and the cerebellum? So that's,
Okay, come on. That's well, I'm gonna let you
yeah.
answer that.
No.
That's
You,
that. It's anatomical too,
anatomy.
right? Because here we go. Let me pull this up.
Oh, you'll show a picture. That's it.
Yeah, I'm gonna see if I have a good picture. Because I mean that is um let
Yeah.
me see. I have a slide here. Because that's a good, even though it's an easy question,
And
that's a
while you're finding that, I'm going to
I'm
throw you
trying to
one.
pull it up.
Okay, I'm going
I
to throw
have
you
a
one more that you hope you won't have to think much about. How do the white spots on the MRI correlate with SPECT results?
So white spots, and I'm trying to do two at once. See,
I
that's
know
why me to
I'm
have
stressing you.
ADHD.
I'm
I'm
stressing.
trying. I can't
I'm
keep up with you, Eric. But honestly, when they say these it depends on what the white spots are, right? So white spots to me, it can be non-specific white matter
right.
changes.
That's what it
It's
usually
plaque,
is.
it doesn't. Oh God, I can't find my picture. And that's just non-specific. Whereas when you're looking at functional SPECT scans, that's showing you exactly where the location is, what area of the brain is involved. And so the white matter that you're seeing on these different images are completely different. Our white, what I was showing you on the active scan, is tracer material and showing the activity level. And on MRIs, it's kind of non-specific. Well, I can't
It's
find.
just basically, it's a sign that there's been inflammation in the area, and
Mhm.
yeah, there's tiny areas of, loss of change of fibrosis, not really fibrosis, but loss of some neural tissue, but tiny little areas. And so
Right.
it doesn't, it can be from just, chronic migraines, a little extra high blood pressure in the brain,
Hmm.
or lupus, or,
Hmm.
yeah. So that's why they're very non-specific,
Yeah.
the T2 changes.
And that gets so
That's,
frustrating.
yeah. Uh, and the thing is that many people can have a ton of white spots in the brain and be totally fine.
Exactly.
That's the answer. So it has to be in the setting
Hmm.
of the clinical presentation. It doesn't mean anything in and of itself.
All
So
right. I think I'm
let me
trying to
see if there's
see. I
anything
can't
else
share.
if you can
Sorry, I'm
add.
trying to share my slide. But yeah, so just knowing that you want to really get specific
Right.
into looking at the specific areas where they're
Right.
changing.
Well, just, I mean,
Well,
because
here you go. I can
a
just, I
picture,
don't want to make sure we don't run out of time too, because I thought it would be easy for me
but
to
you can't
find a
find
quick
a good
picture.
one.
But I'll tell you, I was having trouble sharing my slides just now, but I'll just let you know basically, and I'll bring it up. So the cerebellum is kind of behind the brainstem, okay, under the back, which is the occipital lobe. Occipital lobe is responsible for vision. And so that's where, and so the brainstem is below the cerebrum, right? So it's now, and it connects to the spinal cord. So let me just, I think I have a picture, guys.
Yeah.
Thank you for
But
your patience. This is a
and
kind of
and
cool.
and while somebody
Here we
asked,
go. There's the picture right here. So yeah, so the cerebellum, like I say here, the what we used to call small brain, and that's the behind it, below the cerebrum connects this brainstem connects. So they're kind of responsible for different things, is the way I think about it. I think of, like we said, we talked about the how there's a feedback loop with the cerebellum in so many areas, cognition, motor, etc., mood. And then the brain stem, I think of more for just the vital functions, right? Sleep and breathing. So yeah, so those are kind of the differences. Okay, so I think that's probably the
that's
best I can
that's
do.
that's that's gonna have to um severe. Okay. Yeah. Can you heal the cerebellum after a severe car accident or post-concussive syndrome, like and you know the
I mean,
low.
the brain, we do have neuroplasticity, right? where we can have some improvements in brain function in different areas, depending on how aggressively we get with our treatment modalities. Most often, I've seen it with hyperbaric oxygen, where you've had that improvement. But I always like tell patients we don't have the Lazarus effect. So if there's an area where there's cellular or neuronal death, right? Depending on what the problem is, I can't revive that. But at the end of the day, we are learning all the time how well the brain can heal cells and restore cells that have been damaged. So that's kind of a good way to approach that question is that sure, the nervous system can rebuild itself. You can have neuroplasticity.
Yep.
However, depending on the severity, if you have something atrophied, then that's different. Or even in neurodegeneration, like with multiple sclerosis, people always ask me about that and cerebellar involvement, and then like autoimmune neurological diseases when you have these autoimmune antibodies, anti-GAD is one, 65 is one, but those can improve, right? It can heal and be restored, but depending on the level of damage, because if it's atrophied, I haven't seen that improve. What
Yeah.
about you?
Well, I would say tune in at the end of the year. We're going to have a series on uh, peptides and cutting edge therapies, and hopefully we're going to have some people talking about different stem cell therapies, which again, all new, expensive, hard to get. But they will, but this is not new work, I have to
Right.
say. I mean, people have been using stem cells for neuroregeneration for 25, at least 25 years that I know of, probably even a little bit longer than that. And and in the right hands, in the right patients, they do really work.
Yeah.
It's just that yeah, it's hard to do in America because of our regulatory systems, and it also is difficult because there's a lot of people selling snake oil, like this will definitely work. No,
Mm-hmm.
but there
Mm-hmm.
is work out there that's very exciting, and
Yeah.
so that people are having regeneration. I keep saying one last question. Someone asked a question between because I think it just ties together how the whole brain ties together, the Parkinson's disease and cerebellar function.
Mm-hmm.
And we'll end
So
with that one. Just
I'm sorry.
we're going to end with that one because we're going
Oh,
to
you sure?
yeah.
Because I can talk about this stuff all day. So when we're thinking of Parkinsonian and cerebellum, we know that Parkinson's disease is more of a movement disorder, and we do see over and over again that with knowing that there's compensatory. I'm just thinking it through hyperactivity in early Parkinson's, you're going to have that increased activity of the cerebellum to compensate, right? So there are not a lot of studies that show that, but I have seen that in my practice. And then you think about that tremor that goes with Parkinsonian features, that resting tremor. So that's kind of a classic kind of loop between the cerebellum and the thalamus. They call it cerebellar thalamus, I think cortical loop. If I'm wrong, I'm sorry, but I think that's what it's called. And that's distinct for that dopamine pathway. And then you kind of see this degeneration of the cerebellum and like a certain form of Parkinson's. I saw that in a sad case. It was a patient who had Parkinsonian features, but also had Bartonella. And then we just saw like over time, no matter what the treatment was provided by their doctor, they just started having this multi kind of systemic cerebellar type atrophy, which you can also see. And that's when you have direct degeneration that can also occur. So there's definitely a connection. And in early Parkinson's, you can also see that area. Remember, I talked about the basal ganglia that circuits be involved. So there's a direct correlation that you can see on SPECT scan imaging and also just data,
Yeah.
textbooks.
And what's so nice um, is just not so nice, but just always remember that in early diseases and especially atypical presentations, when you are told that you have atypical Parkinson's or atypical MS, think tick-borne disease,
Yes.
and I always have to add mold, but just in my opinion, I do not believe that mold is, I don't want to say ever, but is rarely the only issue because
Right.
mold is ubiquitous. I mean, it's everywhere. Again, just like the last words, the tick-borne diseases, there are plenty of people who have tick-borne diseases who are asymptomatic. So it's something else is happening in your system that's not allowing you to keep them in check. Just like
Mm-hmm.
you're not, like you can't deal with and get rid of the mycotoxins,
Mm-hmm.
detoxify them. There's always something underneath that's causing these problems.
Yep.
Unfortunately, we can't go to those sometimes directly. We do have to treat the top things first sometimes, but it's not, I,
Just one.
it's
It's not
not
just one.
usually just not one by the time it's interrupting your life.
Yes.
That's
And
the
your brain.
and especially your brain. By
Yep.
the time it's got your brain, a lot of stuff is happening. So,
Exactly.
Ebony, as always, this is great, and we'll do this again because I think, and we don't have to focus on the cerebellum. That was a little educational. That was my educational request. Just focusing on how it's this is a special tool. It's not one we use all the time, but it's one that I think people should know about and have a better idea of when it's really for them and going to give them the insights that they need to help them. So, we'll meet again and we'll chat more about the SPEC scans and what you do at the Amen Clinic.
All right. Well, thank you. Oh, I also forgot a good thing. We're looking now, I'm seeing more patients with the gut-brain axis. If I can figure that out one day. Or
Oh,
the
yeah. Well,
specs
we
and
had a
the
little
gut
question about
brain.
about that. Well, that's
It's coming soon, guys. I'm still looking at it, but that's
okay.
my next passion too. It's what does that gut-brain axis really look like?
Oh, yeah. And like
Coming
always,
down the top line.
multiple levels, but I'm counting on you.
One day, one
We'll
day.
definitely have you back for that one. Okay. Thank you
All
so
right.
much. Blessings.
Thank you, everyone. You guys have a good one. Thank you for listening.